Okay guys, so we are done with our break, so let's talk about the remaining part. So now, first I like to read these lines. So the serous coated organs which fill the abdominal cavity so that the visceral surfaces are in contact with one another or with the parietal peritoneum. So space between them is only potential, not actual, and it contains only a few milliliters of tissue fluid which lubricates adjacent surfaces so they can glide over one another. This is the general peritoneal cavity or greater sac. So don't confuse. Somebody was asking me that you said it's a balloon, so who's the air and what is that? So it's a potential space. So every organ is growing and growing and growing till it fill up this whole of this cavity, and we can understand how these organs they move, they glide on each other. So now, previous section we were talking about the sagittal plane. Now I have taken a transverse plane, and we have just talked about how to look and how to address a section. So same formula is applicable here. You can see the first we placed the vertebrae, then we took the the walls, and then we took these vessels. We can identify this aorta and inferior vena cava. Kidneys are being shown, liver has been shown, right side, spleen is shown on left side, stomach. See, if you use this formula, it is applicable everywhere. Okay, so now where is my right and where is my anterior and posterior? The same orientation. So these labels, we talk about them already. So these are my rectus abdominis muscle, which we have covered with the section of anterior abdominal wall. These are the parts of the kidney, the suprarenal glands. Look at it. So this is how my parietal and visceral peritoneal layers, they have been seen while in a transverse section. And now, what are we learning here? You can see that parietal layer, we can see the visceral layer. It's the same thing, but this is in a transverse section. What is happening there? What is this? This is my falciform ligament. And what is that? Peritoneal cavity. Are we good? Now, what is that? Any idea? Guys, it is a little different, but it's the same. That's my greater sac. And look at it. This is a section. So this is the whole thing is greater sac, and this small portion only. That is my lesser sac or omental bursa. Another name for that is omental bursa. And where should be my epiploic foramina? Who will tell me? Just think. The boundaries we set for that. I'm sure you can make it out. And that's what my lesser omentum. We said the extension of the fold of peritoneum from the stomach to the liver. And it has two components to it, hepatico-duodenal and hepatico-gastric ligaments. Two components of that. And look at it. This is what? In the anterior free border, we have the portal vein, hepatic artery, and common bile duct. Posteriorly, we have inferior vena cava. Below, we have duodenum. Above, we have liver. And that's my epiploic foramina where the arrow is. So this is my epiploic foramina, omental foramina, foramina Winslow, so many names for this structure, this pathway. And that's my splenic artery. Look at it. See that from the abdominal aorta, we have celiac trunk. From the celiac trunk, we have a branch called splenic artery. It runs close to the what structure? Pancreas. Excellent. And then it's going towards the hilum of my spleen, and from there it gives short gastrics, and shortly we'll be seeing that. So splenic artery, it's going through that, and it passes a communication between the kidney and the spleen. So what should be? Can you name that structure through which it passes? And look at it. And now from the splenic artery we have branches which are going to the fundus of the stomach. And this communication between the spleen and stomach, what name should be given to that? We call it gastrosplenic ligament. And if somebody asks you what passes through this gastrosplenic ligament, the answer is short gastric artery. And then what is that structure? Between the kidney and the spleen. This is my guess lineorenal, splenorenal, so many names. Lineorenal or splenorenal ligament. Lean word used for spleen, and renal is renal. So lineorenal or splenorenal ligament. And what passes through that? Splenic artery. Excellent. Not only splenic artery, but splenic vessels and tail of pancreas. Are we good with that? That we need to understand here. Now, we know that this lesser sac, we also call it omental bursa. So guys, if there is any perforation within the posterior wall of the stomach, the fluid can go and can stay within this area. And that is my omental bursa. You remember once I was asking you, what is stomach bed? Bed of the stomach. So this is the bed of the stomach. What are the structures here? We can see here kidney, left suprarenal, splenic artery, transverse mesocolon, and pancreas. Pancreas is not shown up here at this level, but that is there below down. And this is my stomach bed. So any perforation in the posterior wall, due to any reason, the fluid will come and accumulate where? In the omental bursa or lesser sac. Don't forget this point. So structures making up the bed of the stomach also form its posterior relation and includes what? Left crus. What is crus? Part of the diaphragm, upper pole of left kidney, left suprarenal gland, splenic artery, and pancreas. So if somebody asks you this question, who makes the bed of the stomach, who's making the, then this should be the name for that. And I told you its clinical application. If there is a perforation in the posterior wall of the stomach, that's the site where we can find fluid accumulating. But remember, what is the status of this person? He's lying supine. If he's standing, that will be a different position. Then the answer will go different. So if the person is supine, like sleeping on the bed, like you and me sleeping on the bed, if there is any perforation, it comes to where? To the lesser sac or omental bursa. But if this person is standing, then the story is different. And with each variation, it goes different. I hope this point is very clear in your minds. Now, let's look at it. We have opened the anterior abdominal wall. We are looking at what? Stomach, liver, transverse colon. And from there we can see this hanging apron-like structure, yellowish in color and enriched with blood vessel. That is my greater omentum. And can you see that these are the folds which has been made in the anterior abdominal wall? 5 folds. So this is right now I'll be focused on the greater omentum. So I hope everybody, this is also called abdominal policeman. If say any perforation, any issue, so this greater omentum goes and close that area, curtain off that area, and it localize the spread of any infection may erupt from any of the ruptured tubes, part of the intestine, appendix, or any other structure. So that's the function, clinical correlation of greater omentum. Let me say again, greater omentum. We all know it's part of the peritoneum which hangs from the stomach and the transverse colon, just behind the anterior abdominal wall, enriched with the blood vessel. It's a hanging pattern, a curtain, sitara, and what it does, it's called abdominal policeman. Its job is to localize any perforated area, to localize anything where there is some issue. And we can also use it for surgical interposition. I'm sure you don't know, you're not aware of this word, but if you know, it's good for you. Now, we have lifted the stomach. So by lifting the stomach, I am exposing for you what? Omental bursa or lesser sac. Just, after making this incision, we lift the stomach, the greater curvature of the stomach. And as I was telling you, who is in the posterior relation of my stomach? You can see pancreas, you can see transverse mesocolon, you can see splenic artery. And if I explore a little bit here, you can see slightly here, the left kidney and left suprarenal gland. So that's the space. If there's a perforation in the posterior wall of the stomach, the fluid can accumulate here, and that is what? Lesser sac or omental bursa. This point needs to be very, very, very clear. And look at it, epiploic foramina, through which we enter the lesser sac. I hope we are clear about it. Now, let's see it. I put these pictures here. So, everything which I was just talking, the structures who make my omental bursa, stomach has been removed. And you can see exactly what I was talking, those structures who are present in the posterior relations. And look at here. So posterior wall, you can see more precisely. And this is the even through the greater omentum. And we can see very clearly kidney, suprarenal gland, pancreas. If we come here in a transverse section, this is what I was showing you in that previous section. Am I clear? I was telling you this is stomach, and this is the omental bursa or lesser sac, and this is where we have, and that was what? Remember? That was my epiploic foramina. And if you see in this view, you can see the greater omentum, you can see the lesser omentum, and you can see the location of the omental bursa. I hope I have tried to go over in different views and different concepts. This is representing this way and this one is representing other way around. So we can understand each of the given concept. Now, omental bursa or lesser sac is the portion of the peritoneal cavity behind the stomach, and the lesser omentum, a double layer peritoneal structure connecting the lesser curvature of the stomach and the proximal part of the duodenum to the liver. We talk about that. Through what? Through lesser omentum. The omental bursa communicates with the greater sac via the epiploic or omental foramina located posterior to the free edge of the lesser omentum. Now you can see again it has everything is being lifted. Now you are looking into the infracolic compartment. So you are looking at in the upper side at this area. On the left side we'll have jejunum, and this all remaining is the ileum. Are we good? So you can see the transverse colon, you can see the transverse mesocolon, and you can see the greater omentum. Are we good? You're looking at the appendix, you're looking at the ascending colon, hepatic flexure will be inside, transverse colon, splenic flexure. If you remove this into small intestine, you can see the descending and sigmoid. Now, what I'm showing you different mesenteries. This is transverse mesocolon. So mesentery of my transverse colon. Mesentery or the mesentery. We don't call it mesentery, we call it the mesentery or main mesentery, mesentery proper. And this is showing you the attachment of my, this is a 6 to 7 centimeters, and it gives an attachment to 6 meter structure, the whole of the jejunum and ileal thing, right? So this is the base of their attachment, and through this we have multiple jejunal and ileal arteries, branches of my superior mesenteric, and they are supplying. And this is the mesentery of my sigmoid colon. Remember in the dissection video, I was emphasizing on that. I hope we are clear. So let's see them in a bigger picture. So there you go. There you can see that mesentery of the transverse colon, the mesentery, and the mesentery of the sigmoid colon. Are we clear? So we have talked about the similar structures. And we need to be good with these concepts. So now, seeing again, we can see this, how transverse colon has been cut in between. So you can see that this is where transverse colon was cut, mesentery of the transverse colon. This is the mesentery extending from where? From the duodenojejunal flexure. This is my terminal ileum, and this is what? Look. Mesentery proper or the mesentery. And this is the mesentery of my sigmoid colon. Now, we have removed everything. Now you can see the mesentery of the transverse colon, mesentery proper or the mesentery, and the mesentery of the sigmoid colon. Look at it. This is the place for the cecum, ascending colon, hepatic flexure. Transverse colon is not attached with the posterior wall, so that is not shown here because it hangs with this mesentery. Now you are looking at the descending colon, and then it becomes sigmoid, and ultimately it becomes rectum and terminates as the anal canal. So behind that, can you see that those structures, all of them are retroperitoneal structures. So now another important concept, transpyloric plane. What is that? It runs between through my pyloric part. So transpyloric plane. Corresponding vertebral level is L1. Important landmark in the abdomen, important structure located near it. And what abdominal structures organs found at this level include stomach, spleen, duodenum, and pancreas. So these organs are located, so now let's put them here. We are looking at posterior abdominal wall, diaphragm, aorta, and inferior vena cava. Look at it, pancreas, duodenum, So what is that? Dotted line is the first part of the duodenum. The second part of the duodenum, the third part of the duodenum, and the fourth part of the duodenum. Are we good? And this is my duodenojejunal flexion. And this is my kidney, right ureter, and suprarenal. That's my spleen. Hilum, my splenic artery, and this is what making of my portal vein. We know that who are these two veins? They join to make portal vein where? At the neck of my pancreas. So splenic vein and superior mesenteric vein. They joins where? At the neck of the pancreas to make what? Portal vein. And this portal vein enters into the porta hepatis. And now you can see that portal vein is formed and it's going towards my liver. Liver is not shown up in this image. And this is common bile duct. And this is my left kidney, left renal vein, and left ureters. Basically, why I'm showing you this? Just to show you the level of transpyloric plane. And then we know about it, that celiac trunk you are looking at, it gives the, what is that? Common hepatic, left gastric artery, splenic artery. So these are the three branches from there. And then, it further divides into my common hepatic gives my gastroduodenal, and on above ascending is the hepatic proper, and below is my descending will be my gastroduodenal artery, and then it gives anterior and posterior superior pancreaticoduodenal arteries. There you can see the superior mesenteric artery which has been going up or going below, and then it gives inferior pancreaticoduodenal arteries. One is anterior, one has to be posterior, and they are anastomose. So guys, this is the point which is really important, because look at it, at this point I have supplies from my celiac trunk and from my superior mesenteric artery. So what is that cutoff level? So we can see that this is how the duodenum and the head of the pancreas has been supplied. They get their blood supply, and this line at the second part near to the ampulla of Vater, this dotted line is really important, and this dotted line indicates level of division between the foregut and midgut derivatives. So this much part, first part and half of the second part from the foregut, and remaining from the midgut. So this is from foregut, this is from the midgut. So this part gets its supply from the artery of the foregut, that is celiac trunk, and the lower part, half of the second, third and fourth, they are getting blood supply from the artery of the midgut, and that is by superior mesenteric artery. These points has to be very, very clear with you guys. So now all these structures which we have talked about, you can see hepatic flexure, transverse colon is being cut, splenic flexure, and all of them are retroperitoneal structure, and we talk about it. The transpyloric plane run at this level. Are we clear? So this is root of the mesentery. We talk about that. Thank you very much. So now I'll be coming back to you with the last part, the third part. There are not many. There are 4 or 5 slides, but that is the most important concept all around. Thank you very much.